Thank you so much for joining us and welcome to Nashville. I'm Mariann Yeager. I'm CEO of the Sequoia Project, and I'm just thrilled to kick us off on our 2-day meeting that we're co-hosting with Care Equality. It's going to be a fun-filled 2 days, lots of rich topics. I like to say that this is really the brain trust of interoperability, and just really look forward to the very rich discussions between the sessions. So getting us kicked off today is the Sequoia Project Board Chair, David Horrocks. So David, take it away. And I will hold this.
Thank you. So thank you, Mariann, and hello. I am so pleased to be here with you today and to welcome you on behalf of the Sequoia Board of Directors to our annual conference and the Care Equality's annual conference too. And we'll have an opportunity later in the conference to acknowledge some of the many people who make the Sequoia Project tick, including my fellow board members. But right now, I want to just start by acknowledging our CEO, Mariann Yeager, who is approaching 14 years at the helm of the Sequoia Project. I think we should. So thank you, Mariann. And wow, have we seen tremendous change in an industry during that time and a growing impact for this organization. We are, of course, very closely associated today with TEFCA, and we're all very proud to see yet another successful Sequoia-led initiative that's creating real-world health information exchange. But the organization does much more. Sequoia strives to be the primary point of collaboration for industry leaders, including all of you. And we want to be a venue where the challenges of health information sharing can be tackled. And in a moment, I'll be introducing two of the nation's chief policymakers for health data sharing who are leading the administration's efforts to improve care and enable innovation. And Mariann works very closely with them at ASTP and at CMS more broadly. And we are very excited to have them here with us today. Now, last year, my introduction was also of the national coordinator serving the prior administration. And of course, Sequoia was working closely with them, and we were very, very excited to have them. Mariann has worked successfully, I believe, with 6 of the 9 national coordinators. Yeah. So last week, as I just reflected on what to say this morning and reflected on the moment, we were in the midst of the government shutdown. And first I was like, am I going to be able to get there? Right. And I'm struck that the temperature is really high on so many policy issues, including health-related things, how best to achieve healthcare affordability and innovation, and how to sustain a safety net, and much else. Yet, we in the room today have been successfully working together in good faith, some for almost 14 years, to drive progress with National Health Information Exchange and to enable the many benefits that patients and the country can receive from the availability of health information when and where it's needed. So as we kick off the conference, I invite all of you to continue that good faith effort to advance the cause this week and all year long. So we have 2 keynote speakers today. Amy Gleason will present on CMS Digital Health Ecosystem strategy. This bold new vision includes a call to action for health information networks, app developers, vendors, providers, and innovators to share information to empower people and improve care. I think we're going to hear a little more what a CMS aligned network is. Is that right, Amy, as well? And then Dr. Keane will discuss HHS Secretary Kennedy's directive to increase resources dedicated to curbing the harmful practice of information blocking and increased enforcement against healthcare entities that block access the data exchange and the use of health information by patients and others who have a legal right to the data. So after opening remarks, both will join Mariann for a fireside chat. So by way of introduction, Amy Gleason is the administrator of the U.S. Department of Government Efficiency, or DOGE services, and a strategic advisor to CMS, Center for Medicare and Medicaid Services. Amy began her career in nursing, I understand, right here in town, and has specialized in advancing healthcare through technology. She brings a deeply personal perspective to her work, shaped by her experience as a caregiver to her daughter, who is diagnosed with a rare disease at age 11. Today, she leads the national initiatives to modernize healthcare technology and improve data interoperability. She previously served as the Chief Product Officer at Russell Street Ventures, where she led digital health innovation at Main Street Health and CareBridge. Amy has also served with the U.S. Digital Service at the White House, where she created the National COVID-19 database and led major efforts such as the Data at the Point of Care and the Pandemic Ready Interoperable Modernization Effort, or PRIME. Very good job on the naming of that. I understand that I knew you were close by, but you say you're just blocks away here in Nashville. And we're very happy to have you here, Amy. Dr. Thomas Keane serves as the Assistant Secretary for Technology and Policy and the National Coordinator for Health IT, the nation's 9th national coordinator, I'm told. Both an engineer and physician, Dr. Keane served a prior stint in ASTP and also as a senior advisor to the Deputy Secretary of HHS. Among other duties, he was an administrator of the COVID-19 Provider Relief Fund and led the development the development of the AHRQ National Nursing Home COVID Action Network. Prior to training as an interventional radiologist, which I believe you did in Albany, where I spend much of my time, Dr. Keane worked as an enterprise software engineer and a finite element software developer. I'm having flashbacks to finite element analysis panic during my heat and mass transfer final examination. I understand that you live in DC, and I am very happy. We are very happy to have you here as well. So, Amy?
Good morning. Good to see everyone. And yes, I'm the crazy person that lives on Broadway, just 3 blocks from here. So I love Nashville. If you need tips of where to go, I might know some suggestions. So I am here to talk about our journey in the health tech ecosystem. So this is my daughter Morgan, and some of you have heard her story before. She's now 27, and she looks pretty healthy in this picture. But we have had quite a journey through the healthcare system. When she was 10 years old, she was a competitive gymnast and cheerleader, and she was very athletic. We called her the Energizer Bunny because she just never stopped moving. But then she started having all these series of symptoms that just seemed unrelated at the time. So on the right side of this picture, you can see she has these rashes on her knuckles and her knees, but she was a gymnast and she hit the mats a lot, and we didn't really think that much about it. And she kept getting them over and over. The doctors kept giving her steroid creams, but it didn't really help very much. Then she started breaking a lot of bones. She broke several bones over the course of a year. And some of them were doing gymnastics, which isn't that surprising. But others, she was just walking down the street or bumped her elbow and chipped a piece of it off. And we kept asking the doctors, like, is there something wrong with her bones? Why does this keep happening? And they couldn't figure out what was going on. Her bones look fine, they said. She had strep throat several times. She had her tonsils out. She had stomach aches and headaches, and got to where she would just say, I don't feel like going to school. I'd go to pick her up from gymnastics and she was sleeping when I came to pick her up, and her coaches like, she was just too tired today. Over time, she lost all of her tumbling. From first she couldn't twist, and then she couldn't flip, and then she couldn't back handspring. And before long, I could do a handstand longer than she could. And the real challenge was that the providers couldn't see all of the information that was going on. All of it was siloed across their different EMRs. So the orthopedic was looking at her bones, and the dermatologist was looking at her skin, and her pediatrician was busy handling all these miscellaneous things. But nobody could see all of this information together. Or I think someone would have said, why is an 11-year-old going to the doctor so much? So 457 days later in our journey, where she could not stand up off the floor or walk up the stairs by this point, she finally got a diagnosis. That's about a year and 3 months for those of you that need help. But so we went to the dermatologist, and they were going to do this laser treatment. And the insurance company said, we think you need a biopsy before we're going to pay for this. It's the only time prior auth ever helped us. And they did a biopsy, and it found that she has a rare autoimmune disease called juvenile dermatomyositis. It's a life-threatening systemic vascular disease. And she now sees 12 doctors over 6 health systems in 4 different states. She takes 21 pills a day. She gets 2 infusions a month. And it's a full-time job managing her healthcare. She actually says that her disease is rare, but her experience is not. So even though it seems like she's an abnormal use case, the things that she experiences happen to everyone. So we've achieved a lot of electronic use, especially with the meaningful use push. We got people to use electronic medical records, but I'm here to tell you it has not solved this problem. My daughter now has 47 patient portals. Her information is split and siloed across all of these different systems. No one can see all of it together, not her, not her doctors, or anyone else. And so some of these were just like one-time visits. She went to an urgent care or to an ER. Others are her doctors that she sees over and over, but they all contain pieces and parts that are important to her story. So when I came back into the government this time in January and started talking to Dr. Oz, Administrator Oz, he is a very big proponent of how can we use technology to help beneficiaries, help patients have a better healthcare experience, and how can we use that to modernize healthcare as a whole and reduce the cost of care down as well, especially with chronic disease growing as it is. And so we did an RFI back in May to try to figure out what everybody else thought about why interoperability wasn't working. So it should work on paper. We have Meaningful Use has done things. We have TEFCA and the Cures Act. And if you look in certain areas and pieces, it does work fine. But then when you look at it as a whole, it really just doesn't. And so we did this RFI, and a lot of you, I'm sure, responded. We got a lot of feedback. We did an event in June at HHS to really do some like sticky note whiteboarding exercises. Got a lot of feedback. And so we really said, what if we really just tried to dream big and didn't do everything by regulation? So I've learned the hard way that regulation doesn't really get you where you need to go. So I wrote the data at the point of care rule with Alex Muggy, wherever she is in here, and the provider access API back in early 2020. And I came back in January and realized that the date it has to be in place is January 1, 2027. So 7 years from writing that to getting it into practice is just too long. And so we really wanted to try to find a way to make things move quickly. I think the other thing is when we launched data at the point of care, it was the first bulk fire implementation. And we were very excited. And the day we launched it, we realized there were all these things that we would do differently. So when you write stuff down, you come to consensus, you have all these ideas. As soon as you test them, you realize there's changes you want to make. So we launched an initiative on July 30th, and the main call to action was kill the clipboard. And so the main piece of this is the CMS Health Tech Ecosystem that you've been hearing about. And so I just want to first say this is not to compete with TEFCA. All of the QHINs have joined into this voluntary effort. It was a call to action on the industry to say, let's don't wait to try to get consensus and step-by-step build over time, but let's throw out a bold vision and try to figure out ways to get there very quickly, like in 6 months. And will it be at scale in 6 months? No. But will we test a whole lot of things and figure out, hey, these things work and we should move those forward and maybe get them into more consensus groups and get them working? And these things didn't work, and let's find a way to quickly iterate on that and find something that does work. And that can be complementary to the QHIN and TEFCA process as well. But it was also to broaden the tent. There are a lot of people out there that have business models and data that could be a network. And so we wanted to say, somebody last night said, if you think about it, that the CMS Online Networks is dessert and TEFCA is a cake. So I thought maybe that would work. So we'll try that analogy. You can let me know if it worked or not. But basically, it's like there are a lot of different networks, health information exchanges. We had several companies like BeWell, Innovator, and Datavant join in this effort that are not any of those things, but they wanted to be a network and they already have an existing business model to get data and to share data. So we have this CMS aligned network. Then we felt like the two biggest things we heard from all of you that were missing were provider directory. Everyone spends, I've heard there's over 5,000 provider directories. I think it could actually be more. And we spend billions of dollars in the industry trying to figure out where providers practice, how to connect to them electronically, and what insurance they take, among other things. So they have a valid license, et cetera. And so because CMS already does the national provider identifier and they do most of the Medicare providers validation already, we feel like this is an appropriate use of the government to take on something and do a good for all. So our idea here is not for CMS to have all the data and all the answers, because that will never happen, but it is to share what we have and then let you all join in and help us keep it up to date. So we can vouch for whether we validated someone's license in a state and when. We can vouch for whether they're a Medicare provider, whether they have an NPI, certain things. But you all can tell us other information and we can give you that as an API, a data file, and other things. The other piece is patient matching and then trust and patient identity. So we're adding modern identity credentials to Medicare.gov to help start feed the industry of identity validation and verification is important. So we're going to start getting people verified using ID.me, Clear, and login.gov, hopefully at the end of this year. And we'll start to do that to help seed this ecosystem. And we think that can really help with the trust of patient requests and patient matching, because these identity providers have all agreed to add former last names, former addresses, former subscriber numbers, and things like that to help with the matching algorithms and things like that. So the next part is these private sector apps. So we really want these private sector apps to be patient facing. We really put a lot of focus on this effort being beneficiary facing. And so Kill the Clipboard, which is basically the patient can use their identity, get all of their data without knowing the doctor's names, where their EMR is, what their portal login is, and can get all of their medical information into the app of their choosing. And then they can use a QR code or a smart health card link to scan or tap into their doctor's office and share their information to not have a clipboard anymore. Conversational AI is the same idea. Patients can use an app of their choosing, get their records, but then now the LLMs can be personalized based on their records. And then diabetes and obesity are MAHA initiatives. So they're helping, same idea, but personalizing that based on your records. And we're going to start with pushing this to Medicare beneficiaries who are more digitally savvy. And then this is not just Medicare, we're trying to do this all over, but we're using the Dr. Oz Gets Medicare campaign to try to help educate people as well. So we'd like all of you to join us, if you have not already, on our Health Tech Ecosystem webpage. If you Google CMS Health Tech Ecosystem, then you can sign the pledge form there, and that gets you access into our working groups where we're trying to solve all of these sticky issues. So this is not CMS telling you how to do things. This is really a call to action to the industry and say, let's find a way to accomplish something instead of finding a way not to do something. And so we really want you to come and join us. So these are the categories that you can pledge to. You could be a network, you can be a provider that's helping your people connect to the network and kill the clipboard, EHRs as well, payers. Payers we're really allowing to query for quality measures in an operational use case and for their clinical records when they receive a claim for 60 days after. And then these patient-facing apps that we talked about. And I am going to hand it over to Dr. Keane, and we will continue our conversation a little bit.
Good morning, everybody. I noticed in the lead up to this that they had said that cowboy boots were recommended, and I was looking around. I was thinking of going out and getting myself a pair of cowboy boots, and I'm glad that I didn't, because I don't see anybody wearing cowboy boots. However, there were peals of laughter when David made a joke about a heat and mass transfer final exam. So I know exactly what sort of crowd I'm speaking to here. Let's see, where are my slides? Here we go. Okay, so I'm going to talk about ASTP priorities. As I'm sure most of you know, my office, the Assistant Secretary for Technology Policy, is the principal federal entity charged with coordinating nationwide efforts to implement and use the most advanced health information, technology, and electronic exchange of health information. And we continue to advance our mission that spans multiple administrations to improve the health and well-being of individuals and communities by making health information accessible where and when it matters most. Now, I know what most of you are thinking. Quote, accessible where and when it matters most sounds like the tagline for a food delivery app. But we could learn a thing or two from DoorDash about getting things where they need to go quickly at the push of a button. The only thing is that DoorDash doesn't have to deal with HIPAA compliance. By the way, these speeches are written for me, so if the jokes fail, don't blame me. I do have a couple of extemps in here. We'll see how those land. I'll let you know which ones they are. The HHS administration is laser focused on building a person-centered healthcare system. This means giving patients and caregivers the power to access and share their health data, whether it's with a doctor, a family member, or even a nutrition application. The goal is simple. Let's reduce the friction in healthcare so people can spend less time navigating the system and more time living their lives. Many individuals have multiple conditions that they are actively monitoring and managing. We seek to shape a health system where these folks can have all of their information electronically in one place, and where they can share this information when seeing a new healthcare provider, or they can integrate it into a broader lifestyle health app that can help with fitness or remind them when to take their medication. We are close to a world where your mom's glucose monitor talks to her doctor's office, her pharmacy, and even her grocery delivery app so that she can get the care when she needs it without endless phone calls and paperwork. That's the vision we're working towards. In addition to patient access to health information, we are working on efforts to increase data liquidity across the health system, which I'll dive into in a couple of minutes. We are also focused on ways to advance our path to the next phase of health IT advancement. To that goal, I wanted to take some time to share with you a little bit about our upcoming deregulatory plans. As you may have seen in the Spring 2025 Unified Agenda, we are looking at deregulation, including around areas where we have already issued enforcement discretion notices. We understand that there are health IT certification standards that are mature and no longer needed to be part of the certification program. We currently have 60 certification criteria for health IT, and we're revisiting all of them to see which ones are out of date, have become market baseline, weren't adopted, or had no beneficial impacts on patients. So we're going to propose some changes to that, and we're also going to propose some changes or modifications to the information blocking exemptions. We look forward to receiving your comments when the rule is released. All of this is informed by the Secretary's vision and our vision of allowing health information to exchange, to continue to mature and continue to become more liquid. Information blocking. My office is working on several efforts to make this person-centered healthcare system a reality. One of my key priorities is to increase data liquidity across the healthcare system. We remain committed to advancing interoperability nationwide and delivering on a vision where data flows seamlessly, including for patients and between providers and payers, to lower costs and to improve care for all Americans. For more than a quarter century, HIPAA has granted patients the right to access their health information. The Cures Act sought to allow patients to access this health information without special effort. Unfortunately, until now, patients haven't had practical access to their health information. Of course, one of the biggest obstacles to data liquidity is information blocking. Let's be clear, no one, whether it's a doctor, a hospital, an EHR company, or a health information exchange, should be able to hoard health data for their own gain. It's bad for patients, bad for innovation, and quite frankly, bad for business. Information blocking, the practice, for example, of a healthcare provider, electronic health record company, or health information network interfering with the access, exchange, or use of electronic health information, undermines the public and private sector investments in our health IT infrastructure. It frustrates efforts to use technology to improve healthcare quality and efficiency, frustrates efforts to accelerate innovation, and frustrates efforts to provide greater value and choice to healthcare consumers. Since launching our information blocking complaint portal, we've received 1,300 complaints. The majority of these come from patients or third parties on behalf of patients, and most of these claims have focused on information blocking by a provider. We are also receiving an increased number of complaints against developers of certified health IT, and to date, no enforcement action has been taken. Regulation without enforcement is like a New Year's resolution, good in theory, but never realized in practice. That's why we're addressing information blocking as a top priority for this administration. All levels of HHS are engaged. We have allocated funding and other resources to enforcement. The Secretary and HHS leadership team want people to have seamless access to their healthcare data. CMS is looking to leverage its programs to incentivize participation in networks and to take actions against providers who have committed information blocking. Earlier in the fall, we announced that HHS will be taking enforcement actions to hold bad actors accountable. This sends a clear message. The days of information blocking are over. We are partnering with our colleagues at the HHS Office of Inspector General to ensure that the actors are in compliance with the information blocking rules governing the flow of patient information. We are committed to intensifying enforcement activity and taking decisive action to detect and enforce the information blocking statute. We are also collaborating with our colleagues at the FTC, the Department of Justice, and state governments to look at possible anti-competitive business practice laws and other behaviors in the market that prevent access and exchange of health information. We believe that everybody who participates in market wants to be a good actor and a good corporate citizen and wants to empower patients, which is why we announced the information blocking enforcement effort rather than just announcing an enforcement action. But those enforcement actions are coming. It's our intention to work with providers, health information networks, and EHR developers to help them understand what information blocking is and how to comply with the law. Briefly, I'd like to talk about HTI-4. For those keeping track, it is up to HTI-4. It's like software versioning, except with lawyers. This regulation will give doctors and their patients unprecedented real-time access to prescription drug information, helping them identify the most appropriate, cost-effective treatments. Patients, caregivers, clinicians, and payers continue to struggle with information barriers, especially in the case of prior authorization, where a lack of adopted standards and coordination across stakeholders leads to administrative burdens and care delays. This rule finalized several certification criteria through the certification program, including electronic prescribing, real-time prescription benefit, and electronic prior authorization. HHS has authorities that can dramatically reshape the landscape by encouraging, incentivizing, and requiring technology modernization across regulated entities, including Medicare and Medicaid plans and healthcare providers. We will continue to work with our colleagues at CMS, our industry partners, and all of you to find a way to improve prior authorization along critical pathways. TEFCA. We're also making significant strides with TEFCA, which now has 58,000 sites and 115 million documents shared. I want to thank Mariann and the recognized coordinating entity for their years of relentless effort to make this a reality. Under this administration, we have accelerated efforts to use TEFCA to access more and better data. We have added several QHINs, and I believe that the Oracle QHIN is being announced today or this week. Well, congratulations. I'm told, yeah. Did I break news? I went to a bar last night and Alex was there. And I don't really drink much. I don't know if that's true of Alex. No, I'm kidding. And she told me that they were able to get onboarded in 11 months, which I believe is a record. So congratulations, and congratulations to the whole Oracle team. Here's a snapshot of the breadth of TEFCA participants now. And recent announcements by some of the networks have generated industry momentum towards this effort. And at the end of the day, TEFCA aligns with our goal to reduce friction across the healthcare sector. And I'm particularly excited about the individual access services use case, which aligns perfectly with our goal of eliminating quote-unquote portalitis. Portalitis, for those of you lucky enough to be unfamiliar, which I doubt is nobody in this room, is a condition where you need 17 different passwords to access your own health information. With TEFCA, we're working to eliminate this headache so patients can easily find and manage their health data in one place, including through a mobile app. In keeping with the Secretary's goals of streamlining prior authorization, we will focus on bringing payers onto the TEFCA ecosystem. And in keeping with his goal of using data to find the root causes of chronic diseases, we intend to build out our research exchange purposes to support research to support Secretary Kennedy's priority. Let's talk a little bit about the CMS Health Data Ecosystem. Across HHS, we have a focused cooperative vision for the interoperability of health data in support of MAHA. Our work spans across HHS, including ASTP, CMS, CDC, and the NIH, and considers the needs of the care community, including patients, providers, tech developers, payers, and others advancing innovative care delivery. As my colleague highlighted, the CMS Health Data Ecosystem is an accelerator focused on solving some of the challenges that arise in trying to mature health information exchange, direct to consumer exchange at scale, for example, killing the clipboard and conversational AI agents. It will help propel the work of the Secretary, ASTP, and the department. TEFCA supports this accelerated work as demonstrated by almost all the QHINs joining as early adopters because the solutions we develop in the CMS aligned networks can be adopted into TEFCA and can accelerate TEFCA's maturity. We've been involved in the planning and execution of the ecosystem. The CMS Health Tech Data Ecosystem is ambitiously trying to solve vexing problems that go beyond existing networks. They've hired, as I understand, Amy, a number of software developers, is that right? Which in government terms is basically assembling the Avengers. And they've convened a huge number of external stakeholders and working groups, which are focusing on accelerating key areas such as computable consent, reliable provider directories, and authentication and authorization solutions. CMS and ASTP's efforts are complementary, and we continue to enjoy our strong partnership with CMS to implement this initiative. So I want to express my sincere gratitude to Mariann and Sequoia for inviting me here to speak with you, along with all of you in this room today. You've chosen to work in a field where success is matured by things working so seamlessly that nobody notices. Despite representing organizations that would likely be considered quote unquote actors under our information blocking rules, your work is more like being a stagehand in a theater. When you do your job perfectly, the audience never sees you, but the whole show falls apart without you. Since most of you have devoted at least a portion of your career to data liquidity, you know that this work isn't easy or glamorous. There are no ticker tape parades for successful API integrations. No one is making Netflix series about fire implementations. It's not GameStop. All right, these are, when I was reading this morning, I now read these speeches because the person who writes them for me oftentimes has me insult myself in the speeches. And some of them I've read without actually reading beforehand. And it depressed me that all those jokes got a big laugh. And then when I called him out on it, he said, Tom, you have a really self-deprecating sense of humor, so I'm just writing it in your voice, which was basically a way of getting him to blame me for him getting to insult me in front of other people. Anyway, so as I was reading this morning, I thought, okay, if folks were really in a movie, what would some of the movies' names be? And what I came up with were E.T., The Exchange for Treatment. Okay, not so good. How about Jurassic Park Data? No. The Faxorcist? No. All right. Maybe I'll let Matt Swain write the speeches for me from now on. But what you do matters. Every connection that you enable, every barrier you remove, every portalitis case you cure, it adds up to a healthcare system that actually works for people who need it most. So thank you for being in the trenches, for caring about details that matter, and for making my job easier by actually building the infrastructure that I get to talk about. Thank you.
Ago, almost 14 years ago, it was kind of esoteric. It wasn't really a mainstream thing in healthcare, health IT, and it's just remarkable how much it has become sort of central to health policy goals and everything else. And I just think it's just so telling how much that has changed. So many of the folks here today are participating in TEFCA, they're participating in the CMS Aligned Network Initiative, or both. And so I wonder if you could, and recognizing that both of these support advancing nationwide information sharing and all that, I wonder if you could just clarify, how are they different? How are they complementary? There was a session yesterday, I think Michael Marchant talked about how very confusing it was. So here you have a captive audience, and I wondered if you could just take a moment to kind of share your thoughts on that.
Yeah, so I had a little bit of this on when I was speaking earlier, but I think the biggest differences are that anything you do that's regulatory based just takes a long time to move step by step by step. And we were trying to find a way to go faster and test different pieces out. So the main things that we focused on are obviously the individual access as the foundational part of our whole health tech ecosystem, because we're trying to empower the patient with these app tools for the conversational AI, kill the clipboard, and diabetes and obesity. And we will expand that list over time. So we really focused on the no portal piece, not having to remember where your doctors are, sharing patient preferences and consent preferences, and transparency for the patient to know where their data is going. For the provider, we really focused on helping to not have so many debates about what is a treatment query and not a treatment query, by saying that if a provider is a valid provider in the provider directory, they've identity validated and we validated their information at Medicare, that we can basically vouch for them through an API. And if they say they're doing a treatment query and they're a valid provider, then you have to honor that as a treatment query. And if they're doing something nefarious, then you should report that and have it go through the proper channels. And then improving delegation for providers to be able to pick the apps that they want. We also tried to move a little into the operational use cases by having value-based care providers and payers be able to query for quality measure data. So not the whole record, but if I have a breast cancer screening quality gap open, I can query just for breast cancer screening data. Or if I'm a payer and I've received a claim in the last 60 days, I can query just for the clinical information for that. And then lastly, the biggest other part was identity validation and moving to FHIR. So by July, we've said we wanted everything moved to FHIR or FHIR mediated, to have record location services and FHIR subscriptions. So those are kind of the main differences. But I think the other part is just in how we're running. Like, it's a consensus, community-led initiative. People have volunteered, stepped up, and said, "I want to tackle patient matching," or "I want to tackle a record locator service." And it's more getting together and saying, let's say quickly, we think this will work, publish it out, let people try it and use it, tweak it, and if it doesn't work, try something else. And then that gives industry evidence things work, that then TEFCA and the QNs can build into their process.
Tom, what are your thoughts?
Yeah, I haven't seen their, I think really the efforts are complementary. There are great challenges in health information exchange, and Amy and I were just earlier this morning talking about the inherent tension between current interpretations of HIPAA and the information blocking regulations. HIPAA was originally designed to give people right of access and make information flow, but it's been interpreted because of the privacy and security rules to be essentially a form of information blocking. At least that's how it's interpreted by lawyers at health systems and by compliance people. On the other hand, the Cures Act implemented the information blocking laws and regulations, which said in a modern healthcare system, information should flow for the benefit of patients and for everybody else in the ecosystem. And so the question is, how do we address this, inherent conflict? And it's one of the things that the CMS Health Tech Ecosystem is trying to address. And we're working very closely with them. We were just scheming as to how we were going to, resolve this inherent conflict. So we're very supportive of everything they're doing. They've really identified many of the challenges that we face in maturing TEFCA and in maturing health information exchange generally. And as they come up with solutions, we can adopt them into TEFCA, we can adopt them through our regulations. But as Amy points out, the regulatory and rulemaking cycle is very slow. So collaboration between government and the external stakeholders is a quicker way to get to yes.
Well, that is a perfect segue to carrots and sticks, right? So, participation in both of these efforts is obviously voluntary, but, ASTP leads in regulations around EHR certification and information blocking, and CMS, provides incentives for healthcare providers and plans to engage in interoperability. So how effective are the carrots and sticks that are already in place? And what else could be done in that regard to promote that vision?
You want me to go first? That's a good question. We hear from people within the ecosystem that the carrots and sticks should be essentially improved or made bigger. And so just to speak to the information blocking case, the information blocking reg says that if we find somebody who we think is information blocking, we turn it over to OIG. OIG then investigates it. Then OIG, if it that OIG tries to get a settlement or a resolution, if that doesn't work, they send it over to DOJ, and then the litigators at DOJ put together a case, et cetera, et cetera. And and the other mechanism of enforcement is decertification. But all of this requires many steps and much action. So in order to increase the quote unquote stick, we're also we're consulting with states about their anti-competitive practices laws. We're consulting with FTC about anti-competitive practices and antitrust. We're consulting with DOJ because we really believe we need a multi-pronged approach to at least the stick. We want the market to know that we're serious about this, and to the credit of players in the market that we've spoken with, everybody understands that we're serious and is starting to come to us and say, well, these are our concerns with why we don't want to share information or what concerns we have. And we say, well, let's work these concerns out. You're at CMS, so I'll let you talk about carrots since you guys have all the money.
Hilarious. Yeah, so we definitely, obviously, through history have included a lot of the ASTP, ONC things in all of our rules to help drive that. I think we've also been looking at a lot of carrots and trying to reevaluate that. So I don't know how much you paid attention to the Rural Health Transformation Fund that was announced as $50 billion to go to the states to help rural health. And as part of that Rural Health Transformation Fund criteria, the CMS aligned networks piece is part of that scoring criteria. So we are hoping lots of states submitted in their applications that they're going to use some of that money to help advance that. So that's one example of a recent carrot that we've done. We're also looking at sticks at CMS. So we're looking at both. We tend to have both levers, and it's a priority for us to figure out. I think the message is that we want everyone to participate, to share information on these networks. If you're participating for treatment, you should also be participating for individual patients. And we're also trying to find ways for payers to do this. Chris Klomp has talked a lot about real-time payments for CMS. He wants to move to where we can do real-time claim status and real-time payments. And that can be a big incentive for providers to join these networks and get involved. So I think we're looking at everything and anything because we believe this is important. And we want everyone to hear us that we expect every provider to do this. We expect you to respond to the patients as well.
And again, a perfect segue. Both CMS and ASTP have made it very, very clear that an individual's ability to access their own health information is a really top priority. We've been working on it for years. It's so difficult, and sometimes we hit up on issues. The impediments aren't technical. A lot of times it has to do with privacy considerations. But why is it top of the list for you all? Why is individual access so important?
So I think as Administrator Oz and Secretary Kennedy and the President, as he said at the July 30th event, really believe that in order to change the trajectory of chronic disease and administrative costs in healthcare, we have got to empower the beneficiary or patient. So the more that we can help patients get access to the information they need to make the right choices, to avoid ER visits, to be healthier and manage their condition better, the better we can manage with the physician shortages and nursing shortages that are around with the rising costs. And so I'll give you two quick examples from my daughter Morgan and her use of this data that have happened recently. So she wanted to be in a clinical trial for CAR T therapy. She went to Vanderbilt here in Nashville, and they said, I'm sorry, you can't be in it because you have ulcerative colitis. And if we took you off all of your meds, it's too high of a risk to do that. So she went through an appeals process. She's been pretty stable. They still said no. So she put all of her records into ChatGPT and said, I want another clinical trial. Find me something. It's been 15 years. I'm frustrated. And ChatGPT said, actually, I think you're eligible for that trial because I don't think you have ulcerative colitis. I think you have lymphocytic colitis, which is a very similar condition from a treatment perspective. Wouldn't have changed her 15 years of treatment, but it's not as fast progressing and it would make her eligible for the trial. So it could only do that because it had all of her information and could scan through the old pathology and the old reports and things, which of course her nursing mother did not remember from 15 years ago. The second example is she recently was put on high dose steroids because she was having a flare. And it's been a while since she was on 80 milligrams of prednisone. It's been a while. And so she called me one day and she's like, Mom, I really think I have to go to the ER. I've tried all my tricks. I've called Dr. Adams. He said I should probably go to the ER. She's like, but I really don't want to go. I'm like, well, if your doctor said you should go and you think you should go, you should probably go. And she, of course, went to her favorite ChatGPT and said, I don't want to go to the ER. These are my symptoms. And it said, didn't you just finish steroids? Did you do a taper down properly? And she'd forgotten to taper. She'd gone straight from 80 milligrams to nothing, which wreaked havoc. And so she called her doctor back. They worked out a taper plan. She didn't have to go to the ER. And, it's only one person, but you can see when you start to multiply this by millions of people, it can have huge impacts. And plus, it took 2 days for her doctor to actually get back to her to tell her she needed to go to the ER, where she got instant feedback from her ChatGPT, her favorite friend. So I think, this tsunami of patients being able to get, I think that's also going to turn the tides on data sharing, but it's going to reduce administrative burden. It's going to empower people to be healthier. And that's why it's my priority. It's Administrator Oz's priority, Secretary Kennedy, and the president.
Yeah, and Amy's given examples of individual patient empowerment through access to their health data, and that's very much Secretary Kennedy and Dr. Oz's vision. It's our vision at ASTP too. Amy has talked about being able to use existing tools to advise you on care that you should receive and to make your care cycle easier. Many of these tools haven't even been invented, but people aren't going to invest inventing the tools unless they know that they have access to the information that the tools would be empowered by. I mean, other simple use cases include the simple care coordination use case. We've been hearing for a decade and a half about kill the clipboard. It would be wonderful to be able to walk into your provider and that provider have all of your information that you brought in with you on your phone. So much of what's empowered by individual access hasn't even been invented yet or can be conceived of. And, as both a patient and a physician, I can tell you there are terrible physician shortages. To the extent that we can automate a lot of routine care, it will not only provide greater access to patients, but it will also relieve the provider shortage and relieve the demands that as a provider I face when I show up to work and realize that I'm being asked to do more work than I can realistically do in a 12-hour shift. So the potential for individual access is tremendous, and that's why we're also focusing on it in our work with the recognized coordinating entity in TEFCA.
I would add too that the only reason my daughter was able to do that is because I'm her mother and I've obsessively gotten her records over her whole entire journey. But we have tried many of the individual access options using TEFCA, and she usually gets 3 records back out of all of her different records. So it certainly is not responding in the way that she needs it. So she is using good old PDF files that she keeps in a Google Drive. The other thing I would say is that we are in a new frontier. Like Morgan has been open about her disease, which is why I'm able to tell her stories. She gives me new material all the time. But I think most people, some people are very open about it, but others are not. And so we don't necessarily want every patient dumping their data into ChatGPT. We need to develop models that are patient protecting and help them understand what's happening and whether they want to share their data to train models or whether they do not. And that's also part of what we're trying to do with the health tech ecosystem and the conversational AI is figure out more secure, protected ways and just explaining to patients where their data is going. That's an important part of this initiative as well.
Well, I just want to say thank you both for joining us, and also want to make clear that we are here to serve. Sequoia is a nonprofit. We have a public good mission. Our goal is to offset the burden of government, and it's easier for things to happen in the private sector, sometimes make things happen than in government. And I think it's a perfect segue to the next panel, how important it is to elevate the role of consumer as being more of the center of care. So Thank you both for joining us. We're going to have our platinum sponsor from Medi Analytics come up and introduce the next panel. So thank you, Amy and Tom. Thank you.